Welcome to the 21st module of NNF Kerala's online nurses training course in Essential Newborn Care 2020. I'm Dr. Jacob Abraham, and over the next 3 days, Dr. Rani Amina Bashir, an eminent neonatologist from Ernakulam, and Dr. Sundar Singh from Trivandrum will be speaking to you about blood sugar management and the problems that we see in hypoglycemia. I'm Dr. Jacob Abraham, and greetings from Pushpagiri, Tiruvalla. My mandate is to tell you about some of the basic things that we need to know about blood sugar level maintenance and monitoring in newborn babies. And over the next few minutes, I'm going to talk to you about the normal blood glucose levels in babies and how it varies and is affected. I'm going to talk about the causes and settings for hypoglycemia, particularly clinical settings that can be settings for hypoglycemia in newborn babies, and what to monitor and how to monitor. And we're also talking about the methods that we have at hand to look at blood sugar levels in newborn babies. We know that the brain's primary source of energy is glucose, and in the neonate, it is not just an acute concern when sugars go down, but also because there are long-term problems that can happen because of hypoglycemia. When we talk about the fetus is actually getting a very steady, continuous supply of glucose through the umbilical cord from the mother. And this is primarily because of the gradient that is there between the mother and the fetus, and the blood glucose is available from the mother to the baby through the placenta. And this placental transfer is carrier mediated. And the levels of the maternal blood glucose highly correlates with that of the fetus, and nearly 80% of the maternal blood glucose is reflected in the newborn or the fetus. At the same time, placenta is impermeable to insulin. Whatever be the levels of insulin in the mother, the baby gets unaffected by the insulin levels in the mother. The levels of the mother as affected by insulin may then reflect to the baby, but insulin per se is impermeable to the baby, and baby's insulin systems are the ones that are maintaining blood sugars. The fetus oxidizes the glucose that is available for energy needs, and the rest of the glucose is utilized for storage in the form of fat and glycogen in the liver and adipose tissue. All this happens in the late third trimester of pregnancy. Therefore, it is limited storage that we are looking at in preterm babies or in babies who are low birth weight. And that is some of the major settings in which we look at hypoglycemia. As soon as a baby is born, the cord is clamped and cut, and this abrupt cutting of the cord causes cessation in the steady supply of blood sugars to the baby. And this is then maintained around the normal by the baby's mechanisms that then come into play. The baby's mechanisms are the fasting mechanisms that come into play, and we understand that because of the immaturity of the fasting adaptation systems, especially in the first day of life, babies are very prone to becoming hypoglycemic, and many babies can be hypoglycemic, especially if they are not fed early enough. Early feeding is a very nice method to circumvent the problem of the maladapted fasting adaptation mechanisms or an immature fasting adaptation mechanism. In a baby or in an adult, Sugars are maintained between a high and a low, the high being called a crest and the low being called a trough. And when we take a feed, or when a baby takes a feed, the sugars level go up to a normal, which is the crest level, and then come down over the next few hours. And while the levels are oscillating or going between highs, crests, and lows, troughs, it is maintained around a normal level, and that is exactly how a blood sugar level in an individual or particularly a baby is maintained. How does all that happen? Is a fine tuning of regulation of blood sugars during the process of fasting. Blood glucose is maintained at a steady level or at a attempted to be kept at a constant level by the balance of glucose utilization by the organs as well as the supply that comes from the working of the liver. And there are four mechanisms that work in the liver to make sure that glucose levels are maintained, and these mechanisms or metabolic pathways are called as glycogenolysis, neogenesis, lipolysis, and ketogenesis. Now, as the demand in the organs for glucose increase, the liver is able to meet to an extent. Otherwise, it remains steady. And when the demand is less, the liver production for glucose comes down. The liver production of energy sources come down. Glucose levels also are maintained by a fine balance of insulin and counter-regulatory hormones that also work to maintain blood sugars. Therefore, metabolic and endocrine system developmental immaturity can lead to problems in this fine balance. This fine balance also in certain neonates, especially those that have congenital disorders of carbohydrate metabolism or certain problems of hypoglycemia control, can manifest in the neonatal period. That is the reason why we do see many of these, and sometimes these rarer things should also be suspected. So when we're talking about the balance or the seesaw between normal sugar level maintenance, we saw that as blood glucose levels increase, insulin is produced by the liver, by the pancreas, and this is helping the tissues to utilize that glucose and also for the liver to change glucose into glycogen and store it. And all this helps to decrease the blood sugar and bring it down to a normal. If on the other hand, if the sugars level drop below a normal, the balance is then tilted back to normal by the action of glucagon, which stimulates glycogen store breakdown, and this brings sugars back to a normal. So we encountered four metabolic mechanisms and one endocrine or hormonal control of sugar which helps during fasting. Some of these terms we need to understand, and glycogenolysis is basically the breakdown of glycogen to produce energy or glucose. Gluconeogenesis, on the other hand, is production of glucose from other substrates. Lipolysis also contributes to energy production during fasting mechanisms. We are going to talk about how all of these help. And ketone body formation during fasting also helps to maintain energy needs. All this mechanism is also controlled by the hormonal control. Glycogenolysis is one of the major methods of or sources of glucose maintenance post fasting, and it kicks in as soon as the person starts fasting. But we understand that glycogen stores are just about adequate for a few hours, even in an adult. And The stores are not much because the baby's weight is less, and therefore the liver size is less and the storage is much less than in adult. The glucose that is produced from glycogen breakdown is utilized by muscles, organs, including the brain and the RBCs. Gluconeogenesis, on the other hand, is a source of glucose after the hepatic glycogen stores are depleted. And some of the precursors for glucose production is from the amino acids out of muscle protein breakdown, the glycerol from breakdown of adipose tissue by the process of what is called as fatty acid oxidation, and by the production or by the use of lactate from glycolysis. So the amino acids are taken up for gluconeogenesis, as is glycerol from adipose tissue breakdown from triglycerides, and the glucose that is produced is utilized by RBCs, by the brain and the other organs directly. And when it comes to adipose tissue lipolysis, basically what is happening is that triglycerides are breaking down into free fatty acids or FFAs and glycerol, and the glycerol can be utilized for gluconeogenesis. The free fatty acids can be utilized by muscle and kidney for their energy needs, but it cannot be used directly by the brain. The free fatty acid can also be used as ketones by the other organs, but not by the brain. Glycerol acts as a substrate for gluconeogenesis. The long chain fatty acids, just by virtue of not being able to cross blood-brain barrier, cannot be utilized by the brain. And the adipose tissue is broken down into free fatty acids, which either are utilized for gluconeogenesis or is directly used by the kidney, heart and muscle, or by a process of, again, energy release. They are converted into ketones, which are again utilized by organs. So partial oxidation of fatty acids leads to indirect mechanisms for the brain to utilize adipose tissue triglyceride stores. Insulin is the most important endocrine control of fasting mechanisms because it inhibits the other fasting mechanisms. Insulin is produced as a result of blood sugars going up, and therefore fasting mechanisms don't need to work, and that is why it is inhibited by the action of insulin. The counter-regulatory hormones, cortisol and growth hormone, on the other hand, oppose the effect of insulin, and these have different actions on the fasting systems. Sometimes if the insulin levels are high, especially in babies who are exposed to high glucose in utero, like in a diabetic mother, the excessive secretion of insulin can be a cause for very significant and profound hypoglycemia. So we said that insulin in the context of high blood sugars acts on tissues to take up glucose and for the liver to utilize it for glycogen storage, thus controlling the sugar levels, and a feedback mechanism when the sugar levels go beyond the point to the pancreas releases glucagon, which stimulates breakdown of glycogen to again re-maintain blood sugar levels. Now, the pattern of fasting response may be the same in an adult or a newborn baby, but the problems are far rapid in onset, and all this happens because of the fact that there is a relatively larger brain weight to relative body weight in a newborn baby. Also, the glucose utilization rates are much more than adults, and in general and particular, preterm babies utilize more glucose than term babies. So hypoglycemia is an urgent diagnostic and therapeutic challenge in many ways. So before we go to all that, what exactly is normal blood sugar? The problem that happens is that when you look for a definition of what exactly constitutes hypoglycemia or an absolute value of blood sugar, we find it difficult to define. There are different recommendations based on blood sugar levels, but these are primarily with the intention that during the neonatal period there should not be a brain injury because it is a developing brain. And therefore, much of the times we use this so-called operational definition to define hypoglycemia as a level of blood glucose at which we should consider intervention to correct. And for all practical purposes, we will utilize what the WHO defines or what the AIMS protocols, which is universally followed in many ICUs in India, define as hypoglycemia, as 45 milligrams or below is considered as hypoglycemia. And there are certain individuals among babies who are very high risk for hypoglycemia. And these are babies who are low birth weight or premature, especially babies who are less than 35 weeks. And we saw the reason why they are prone to hypoglycemia, because their stores are insufficient. They have not had enough time for adipose tissue to be deposited. They do not have adequate glycogen stores to rely upon. But also, babies who are born to mothers who are diabetic have a problem of blood sugar maintenance, particularly because the high levels in the mother offsets high levels in the baby, and that is counter-regulated by the insulin level that is produced by the pancreas of the baby. And they are upregulated and kept on a higher level to maintain a normal sugar level. So the pancreas in the fetus produce more insulin as a response to the hyperglycemia in the mother. And that ensures that the baby's insulin levels are kept, the fetus's insulin levels are kept higher to counter that high sugar levels. As soon as the baby is born and the cord is clamped, the sugars will plummet and the high insulin levels will make the baby at very high risk for hypoglycemia. Large for gestational age babies, that is babies at term which are more than 4 kilos, are also at risk for hypoglycemia. Now we'll talk a little bit about how blood sugars are monitored. In general, 3 mechanisms are described or now being talked about. We are very familiar with lab values and glucometer values, which are invasive methods. There is also non-invasive methods that are being explored, particularly in the context of adults. And continuous glucose monitors, which may be useful in certain situations, but again, in the neonate may be a little difficult. These are very nice ways to think about for the future, yes, but at present, they are only in the stage of development. Now, invasive blood sugars monitoring would involve the use of lancets, lancing devices, and a machine which will measure the blood glucose level with the use of test strips. There are some that used to only use visual aids by the color that changed on the test strip. These were the very early and primitive test strips. These have undergone refinements, and over time we use a machine to measure the blood glucose levels that is generated on a test strip. And these test strips and glucometers have become refined over time, and we have much better machines that are available at present. But these so-called point of care testing methods are not without their own problems. But let's understand what exactly POC testing means. And POC testing is the measurement of whole blood glucose outside of a designated laboratory space. Now that is something which is of an advantage, particularly because there is a rapid turnaround time, as we call it, because within few seconds we are able to get a report. There is a reduced volume of blood that is required, and it is of particularly utility, particularly usefulness is seen in the care of acute care settings. But there is a problem because accuracy is usually in the normal and hyperglycemic ranges, because the basic glucometers are for diabetics, and they seem to have problems, especially when it comes to low ranges of levels, that means the particularly hypoglycemic levels in the babies. And there are few things that we should look for in glucometers, primarily portability, ease of use, the costs of reagent test strips, the glucose measurement units that it utilizes, and some of these machines also have chips or codes which ensure that you recalibrate it after for every strip pack that is being changed. These are all safety mechanisms that have come into glucometers over the years. The measurement technology is primarily based on an electrochemical process or an electrochemical impulse, which is a result of an enzymatic breakdown of the glucose, and the degree of glucose breakdown by the level of glucose in the blood is utilized to generate an electrical pulse, which is read by the machine as a value which is correlated with blood sugar values. And the different enzymatic methods that are utilized is the glucose oxidase method, the dehydrogenase method, or the dioxidoreductase method. But we all know the practicality of blood sugars, and like I described, the amount of blood sugar glucose is determined by the amount of glucose that is presented to the test strip. If you have a small drop or a squeezed drop where instead of whole blood more plasma is available, or if the sample that is presented has a load of spirit that is also along with it, the blood sugar estimations may be unfortunately lower than normal. So the blood drop needs to be appropriate sized. It needs to be taken from the site after the area has become dry post cleaning with spirit. It is also important that you do not take out a squeezed sample when you are determining blood sugar in newborn babies. We are all aware of the sites that we utilize and the dangers of deep lens use or the depth of breaking skin in certain areas, and therefore designated areas from where the foot you should be able to do blood sugars are very clearly defined. I'm not going to go into details of it. You're all very aware of how those areas are and where those areas are. A few words about lab testing before I conclude. The lab testing has still not lost its primacy, particularly because it is still considered as what is called as gold standard for blood glucose estimation, for blood sugar estimation. And the accuracy of the glucometer with a gold standard, that is the lab glucose oxidase method, is only nearing 85 to 87% in babies who are hypoglycemic. Therefore, lab testing is still not borne out in particularly situations of very low blood sugar values and persistently low values which are sometimes critical to be determined to be managed. We also rely on lab values for critical sample, and we know that fluoride is the additive that is used, and waiting long before analysis might fictitiously bring down blood glucose levels because we are using plasma glucose, which actually kind of is the method that is used for laboratory testing. RBCs utilize glucose, therefore plasma should be separated out for testing at the earliest, and we should not wait for the sample to be processed in the labs. And it actually is an optimum method of blood glucose estimation, or and like I described, there are different enzymes systems that are there by which these analyzers will determine blood glucose levels. It's almost similar to how the other method is, but these are still the gold standard. And the problems that we have with lab values is obviously about the fact that these require larger volumes and we do not get immediate results. We need to have unplotted sample, and errors can be there due to a delay in estimation. So with that, I come to the end of my bit of what I am mandated to do. I will call upon my colleagues to speak to you about the diagnosis and management and the problems of hypoglycemia that you will see in units over the next 2 days. So wish you all a happy learning, and thank you very much to the organizers and to all of you for your patient listening.